presenter this morning is Chuck McGee, and he's going to talk about the work that he's been engaged with Alaska and Allan as well for a number of years, developing the performance management system. And I had the honor of working on this project as a brand new PhD student when I first started my doctoral studies. Chuck was my first research mentor, and glad to come full circle and be working with him again now, many years later. Thank you, Chuck.
Good morning. Glad to have you when you're bright and early and interact a little bit. I want some interaction out of this. One of the pieces that's going to be valuable to us as we go along is to kind of know where people are, who people represent, because when you're talking about performance management system, you've got different tensions at different levels. And so, and we have some new people here. I thought it would be an opportunity to kind of go through and just do introductions and then say whether you, like in the course of this conversation, who you might represent, whether it's like a state mental health authority director or planner, or a private provider or a consumer, which we don't have an awful lot of. Our sole consumer is not with us yet, but I hope he'll turn out to be present. So let's go around and do introductions, just so we know who we have, because I do recognize a couple of these faces. And since Kristen's up and moving already, we'll let her start.
Hi, I'm Kristen Nealon from the Nashville Research Institute.
John Hornick.
Dan Oney with Oney Associates, a behavioral health consulting firm.
Mike Sheldon, State of Arizona.
And so you're going to be like a state mental health authority, mid-level kind of a person. So you've got a commissioner over you. So you're going to have a different role in a performance management system.
Correct.
You have to introduce yourself.
That's what you get walking.
Gina Brimner, I'm a consultant with WICHE.
And I'm Jeff Emmerich. I'm the Deputy Director of the Addictions and Mental Health Division for the state of Oregon.
Lisa Peterson, I'm the Data Unit Manager for the State of Wyoming Behavioral Health Division.
I'm Mimi McFall, the Director of the WICHE Mental Health Program.
Deb Kupfer, a consultant with the WICHE Mental Health Program.
I'm Gina Lasky, I'm a consultant with the WICHE Mental Health Program.
Leon Lopez, Quality Improvement Manager for the state of New Mexico.
All right, the role represented in all of this piece.
Joanne Brothers with WICHE.
Nate Mohat with WICHE.
Bree Walter with the state of South Dakota, and I do the data stuff with them, I guess.
Yeah.
Brooke McConan with Mental Health Partners here in Boulder. The Senior Practice Management Data Analyst.
Okay, so we have a provider represented in the group, and maybe some of you take that role too.
I'm Frank Cornelia. I'm a policy specialist with the Colorado Behavioral Healthcare Council, and we are the membership association for all the community mental health centers and behavioral health organizations and managed service organizations in Colorado, so we represent providers.
Cool. Oh, welcome. Nice to have you.
Sean Dodge, a psychologist for the state of Nevada, representing our agency's Division of Public and Behavioral Health.
I'm Sarah Ross, I'm a postdoctoral fellow with WICHE.
Tammy DeHay, I'm the Associate Director of the WICHE Mental Health Program.
Jeremy Vogt with the WICHE Mental Health Program.
And Holly didn't introduce herself, but we know her from a minute ago. Okay.
Do we have anybody on the phone?
Good question. Jeremy, do we have anyone on the phone?
I heard somebody dial in. They might be on mute, but if they would like to introduce themselves, they certainly can at this moment.
Kathy Cervantes with the state of Oregon.
Oh, Kathy, hi.
Hi. I see that Jeff is there.
Yeah, I am.
That's great.
I'm thinking, wow.
We're sorry to miss you, Kathy. I'm the chair of this group. Anyone else online? Okay, let's go. So who are the players that we're going to talk about here? You know WICHE and the commission, and I I'm not sure you know this, but everyone, the commissioners are the advisory board for the WICHE Mental Health Program. So you are, we are you, and we so you can read that stuff, the Interstate Compact. And I think the one advantage of that is we develop different kind of relationship with each other. We have a different relationship with each other. Nonprofits, we're also a nonprofit. We are an Interstate Compact and sole source with, and our role is to support you. We're going to, and then I'm going to talk about some of the work up in the state of Alaska with the Division of Behavioral Health. And Haines Simeon is on the agenda. He is the leader of this whole effort for the division. He's not the director, but he's the program policy and planning that manages the performance management system there. And he regrets not being able to be here. He did plan to come when we had the meeting earlier. We got rained out. We scheduled the meeting in time, but he could not make it. They had so if he were here, you would get a lot more about more foundational work about what's behind a performance management system. And I'm going to be able to provide you. I'll probably end up more on the data side of it about what comes out. But I do want to kind of have a conversation, and I hope it's a little more interactive than you might hope for. Something I don't want you to go to sleep. But I don't want to just present something. I would like to kind of get some of the ideas about how it's developed. And so the first question is we say, how do you develop a performance management system? Well, the question came up yesterday about, do you want to? Should you, right? So I would like to get people maybe at the different levels saying, let me stop for 1 second. Break came in, so I'd like you to introduce yourself.
My name is Drake Eubank. I'm a consumer survivor from Eugene, Oregon. I'm part of the WSDSG.
So we have a token consumer. I'm sorry, but he's a well-voiced consumer, and you're going to have to represent a lot more people because there's a lot more weight on the other side of this balance when we look at MHOG and providers here. But I know you can do that. Where was it? Oh, why do we want to do this? You know, and I think that I don't know if John wants to make the point, or I could make the point about that you made yesterday. I think that what you pointed out yesterday was a lot of states have done it and done it very well. Put together a performance management system that was flexible enough to change over time, and then you get a new commissioner, or something happens, they've gone away, and that was the argument I heard for. So. Where any commissioners here have some expectation and do it louder? Okay. Any commissioners here have some want to speak to why they might be doing this? And I can speak to Alaska, but what other states are doing a performance management system? Does anyone want to say anything about that? I can articulate why Alaska did it, and I think that it's part of their identified as one of the core functions for the performance management system, and that's actually coming from the state legislator. You know, there is a legislator who has been in place for a number of years, who's put pressure on the division, says, I want to base some funding on outcomes. The legislature wants outcomes, and they want to base some. It's not only outcomes. Their whole performance management system is access, appropriateness, and outcomes. It's all the different names. But they want that, and it affects the funding. So there's quite a bit of tension in that right there. But that was the primary reason that I think Alaska initiated that. Does any other state have that? Who else is doing a performance management system, and where did it originate? Can the State Mental Health Authority just decide to do that, or would it generally come from higher up, legislature or governor? What's the experience in Omaha? Anything, Jeff?
Did you say Omaha?
Omaha. It starts with an O. It's as close as I can get.
I'm hearing Peyton Manning.
Let's try.
Kathy might be able to lend a little bit more credence to this than me because I'm so new. I mean, I was out there as a provider. Kathy, do you have anything that you want to, or?
Not really a lot. Kathleen Newton is our person that does all of our performance measures, but most of our stuff has come from request of the federal government. So that's where we've gone with that.
Okay. Yeah.
And I know that for the portion of the section that I'm responsible for, how are you supposed to help things move along if you don't understand how things are performing? I mean, it's kind of like, how do you run a business without understanding how things are working and moving and how you execute performance improvement stuff? I mean, so that's what we're trying to get to.
Yeah. And
to see how the overall system is kind of doing.
So Kathy mentioned the feds too, so you have an accountability issue, and with the state legislature, you have an accountability issue. And I think what you're speaking to is partially an accountability issue. Mike, did you have some?
Oh, well, in Arizona a few years back, we developed a work group within the Division of Behavioral Health Services, and brought together the data team, quality management, finance, all these other areas, and we did a review of what are the most typical requests we get for information, and can we try to get ahead of the curve a little bit and put them into an annual dashboard, so to speak. So we developed that, and this goes back to our kind of timeliness of data, but every year we refresh it, and it includes everything from the performance on our members on all the national outcome measures. It includes the MISUP survey results, so satisfaction with care, timeliness of services. There's network metrics on it. What's the average distance between a member and their nearest outpatient facility? Those are the kind of things that we get asked quite a bit, and we decided if we could just get them up on our website, we can steer the media or steer any kind of stakeholder who might be asking that towards that before putting any more work on our staff to do an ad hoc deliverable for somebody.
Yeah. Good. What about providers? Anybody from a provider perspective? What is this good, bad, or indifferent? And from a provider's perspective, do you embrace this? I have some things to say about this, and there's an accountability issue. I think there's also a clinical care issue involved in looking at outcomes and access.
We're trying to embrace what's happening in Colorado. Honestly, we do. We understand the value of demonstrating accountability to state and federal funds. It's just a matter of the data systems catching up to what we want to collect. Moving from block grant funds to provide a number of services to shift towards describing value and of care delivered is a challenge. I think I'm working with Zoe and John on a daily basis almost to work through this stuff. So, I think I think from the provider perspective, we want to be able to show our value to the state and the feds and the public. It's just a matter of being able to do that.
Let's let the people from Colorado introduce themselves. We kind of missed you at the end.
Good morning, all. It's good to be here. I'm John Mahalik. I'm the Director of Data and Evaluation for the Colorado Office of Behavioral Health.
Thanks for coming.
Thank you.
I saw Zoe and
Yeah. Zoe Swain, I met some of you yesterday with the Office of Behavior.
Jeff.
So I think that I really like what Mike had to say, because I think that that's like spot on and what everyone else had to say. But I think so also, it would be my dream that one day an end user or someone who's actually going to utilize services can go on to a website and basically take a look at how all the different providers in the system, what they do, how they're performing, kind of line up what they're looking for and how they're, doing on that particular thing, or if they're looking for a particular kind of service, they can go on and find that and actually see how that provider is performing. So it's almost like, you can shop for a provider and grade them.
And that's what we've been trying to do in Arizona. So on the state aggregate level, we split our state into 6 different regions, and we show on our website how each region performs against the other ones, and that's actually been incredibly helpful. It's stimulated a lot of competition between our contractors to show their worth. But then every one of our contractors also has a website that a person maybe needing treatment can go to, and their website will show their major providers and how they perform. So they can do that kind of shopping.
We have had this meeting in Arizona in the past and seen that. I think that would be real valuable for again.
Chuck,
yeah, Chuck.
My experience, I represent a number of providers in Montana legislatively who want performance management and want performance indicators. And the pushback from the state, from the divisions, the behavioral health divisions, and Medicaid is there are no outcomes that you can measure that are short-term that make a difference. And so you have the industry pushing for, we want outcomes, we want a short performance, and we want to be paid for performance, and the divisions pushing back and saying,
that's
there is nothing that we can measure.
So much of that. I've worked in I'm going to say one more thing about a provider, from a provider level. I've worked in a state where they developed some performance indicators, and there was a certain level of trust with the state, and the director changed, and he started using that to leverage the system and pushing a little harder than the system could and the indicators really warranted it, I would think. And so there's a risk involved in doing that. It takes a lot of courage to put that out, and I think it's really important to put some values in place about how we're going to do this and how we're going to understand this, and we'll talk a little bit more about that in a minute. But from a consumer, I'm going to put Drake on the spot here. From a consumer perspective, do you care? Do you really, is it useful to see that stuff? Do you trust it?
Having tried to look at it from the other side, actually would like to make a small amendment to the responses from the Oregon team. They probably, because of their administrative positions, don't know that there's actually a Ecumentra, an outsourced agency, does a consumer survey, probably get about 20% responses. They measure all at the time, just prior to the CCO conversion, which is, I guess, for everybody else is the ACO conversion, healthcare reform. They were bringing back each of the individual MHOs' performances, and that was actually a pretty comprehensive survey. Availability of services, housing, and most of the things that are in the NOMS are in it, plus a few additional measures. So they were actually pretty useful. I mean, you can go on the state website and look at those right now. In terms of things that I've seen that are kind of interesting, innovative, WSDSG was in Utah at one point. I don't remember the name of the county where Provo is, the mental health clinic there. I don't know if you remember they had consumers coming in and checking in with handheld devices. And rather than basing the researcher there had come to the determination that trying to anticipate the needs of the consumers or the critical situations of the consumers by using diagnostic criteria. They actually ask different questions. There's like 30 to 45 questions depending on the survey they were trying to use. But the consumer would use this handheld, go through those questions before seeing the provider, and by the time they saw the provider, they would have a printout of everything that they wanted to ask. That's actually pretty effective. And they actually had predictability for lethality and some other things, and they actually had reductions in some of the critical measures around the well-being of their clients. So I thought it might work in practical. People are tearing their hair out trying to get all these data systems to match up and trying to get client-level data. And if a system was coherent and had consistent standards, you could actually plug those measures directly into the system if you really wanted to, both to measure performance and also to see prevalence of needs in your area.
So it can be useful from a consumer perspective, depending on how it's done. And it's the same thing across the board.
Like most measures, you tend to get answers to the questions you ask, and you get change around the things that you actually look for. I have really actually in many ways would like to make the case for having an outcomes-based set of measures, because the system as it's used and the system as it is based on outcomes looks much different than a rules-based, top-down, academic-based system. And I think an outcome-based system is more effective, but I think the rules genre is more effective at maintaining its political strength. That's okay. And for anybody that suffered under Medicaid, that seems to be my experience of it. So.
Okay, thanks, Gina.
I just was going to say, I think that you raise one of the points that I always think about, which is that behavioral health really needs to start to move towards sharing their data with the people they're collecting it on. We've kind of always done it as a system level or other things, and like Dennis was talking about yesterday, I think with integrated care, we're moving closer to getting data to the consumer or the patient, if you're in a primary care clinic, so that you can learn about how you're doing and base your own income, your outcomes, as well as share, your own health goals. So I think that communication, it really needs to be, system level is very helpful, but it also needs to go to the people who are being served.
Yeah. I think in the presentation after this, Allan's going to demonstrate a model for doing a web-based system that will get it down to the client level. And there's no perfect here. It's the perfect is the enemy of the good enough. It's like take a step and keep moving forward.
I just want to throw in the fact that a lot of consumers like being asked how they're doing. To be able to give feedback on their own assessment of their well-being, as well as being able to write comments and feedback on what they like and what they don't like.
Well, and I think that data needs to really be real time. So, you come in, just like Dennis was talking about, and there are clinics who are doing that, but it's really been integrated care that's pushed you come in, you have an appointment, and by the time you see your provider, there's already data that you share with your provider, as opposed to it's something that gets talked about 3 months later and then, put on a website somewhere. That's not helpful to the person.
Access to healthcare here in Durango and Colorado is it's remarkable.
I think that's what I really liked when we visited Utah back. What Drake was talking about, that handheld device that the consumer came in, they could answer their questions on how they were doing, and by the time they visited for their session, they had results right there on the screen of how that consumer was doing. I really appreciated how the way that Utah has really moved ahead on a lot of that. So I agree with Drake on that, and I don't know who the lady was that was talking, but I agree that we need to have more consumer feedback on things.
That's Gina Lasky here at John?
No, that was Kathy from Oregon.
Oh, I'm sorry. That's Kathy.
Oh, the other person. Sorry. I got a little tiny 2-inch screen that I'm looking at.
Okay, John.
I am pretty sure that the system that you saw in Provo, Utah, is the work of kind of 20 years of research by Michael Lambert and his colleagues at Brigham Young University.
It was. It was.
They've been using this instrument, and not only does the clinician see the results of the survey the person just took, but at one point Lambert was able to also show the clinician a chart which showed how the person.
Is that the work of Jeff Brown and Acorn and WICHE and?
It's very similar.
Very similar, yeah.
But Michael Lambert was really the first one in, but since he's kind of a researcher at an academic institution, he's less visible than Jeb is.
Because it was Jeb and Scott Miller and some groups that did.
I think what was interesting.
Same principle.
Birmingham and Lambert instrument and the same ideas. Yes.
Yeah.
Okay, Kathy.
Well, I think that what was really interesting in hearing from these people is that the consumers were actually coming in and wanting to take these so that they could see how they were doing. I thought that was kind of funny how they were really. Let me take the survey because I want to see how I'm doing today. And so that was really kind of a nice feedback from the counselors and the people that see these clients, saying that people were really trying to evaluate themselves, through this.
Okay, so that was very helpful, thanks. There's some things I do want to cover, and I'm going to move a little bit faster now. But that's the kind of discussion I would like to have here. And so we're going to get into, we could have another conversation about what should you collect and who from. Is it clinical rating? Is it consumer? What you're going to see in Alaska is really going to be a self-reported quality of life. And ideally, you'd have information coming from different sources and all that, but one step at a time here. So what we want to cover is, I'll cover a little bit about the developmental process, and that's been part of it. So if you were in Alaska, every month there's a committee of a group of stakeholders that includes providers and, unfortunately, not as strong a consumer representation, but token consumer too. That's the way this works. But a monthly meeting, that's a whole other issue. We don't get into it. But there is conversation and there is constructive critique, and I'm okay with that. I think that's a healthy thing to have. So we'll talk a little bit about the development performance measures, overview of the two, and I want to talk about two instruments, and maybe we better just talk about the one that we're going to use for an outcome, just in the interest of time. We're going to demonstrate proof of concept. First, we need to show that the instruments can show change. So that was something that we haven't done. So we want to make sure that we have instruments that are useful for the purpose for outcomes and able to discriminate groups. Then we're going to do kind of what we call a cohort analysis, because not everyone has a time one intake and 4 months or 6 months later. You've got people that have an intake that you never see again, or you don't get information. And then you have people that have been in the system for a long period of time. So we're going to break this down into several different cohorts that we can talk about. And then Allan's going to get into more of the technical stuff about how you can take a single measure and combine it multiple measures into a single measure so that you simplify things, because it gets so complex. And then we're going to move into what we're proposing in Alaska to make a comparison of provider with the statewide average to see if there's a difference, a meaningful difference. And so we're going to get into meaningfulness, how do you determine that, instead of just a point here or a point there, what's really worth paying attention to. And so this is my memo to self to slow down and make sure we talk, have an opportunity for you guys to talk. So you're going to see this throughout. And we did this first. What the point of this was, you've got this glacier, it's 200 feet high there, and you've got all this tension in the glacier moving down the mountain meeting valve. We were trying to talk about the tension between the state and the legislature and providers and consumers, and those kinds of things ought to be engaged in a group conversation on a regular basis when you're developing this, and that is all that the voice means. So we're gonna, so I'm not going to cover too much of the background. The voice process, it's really not voice, but these instruments, the two divisions were integrated in 2002, mental health and substance abuse. And Carl Bremner, who was here yesterday, kind of led the way into that integration. When they integrated, they brought stakeholders from both groups together, say, what do we need to know, and how are we going to do this? So how are we going to answer this question about what kind of outcome, what kind of measures we're interested in, and how we're going to do outcomes? And that's where really the foundation for this thing. It's a great process, really good measures. We won't go into how poorly scaled, but they're the same kinds of things that I've seen generated in different places, different states, very, very comparable. And then there was a change in implementation, John's point, I think, earlier, and that was pretty much lost. The instruments were put in play, the providers were still using them, but they weren't being used at the state level. All the documentation was not available at the state level when I went in. Well, the division and the Mental Health Trust Authority funded WICHE project, and I literally moved up there for a year, and when they called it the Outcomes Identification System Performance Project. And they had a lot of stakeholders, monthly meetings, we did technical assistance. I found the documentation online at the contractor's website for what happened in this process. The division wasn't even aware of it. we tried to use the instruments that they had with the way they were scaled, and I'll talk about that. And we try to promote a culture of inquiry, which is no damage here. You know, we don't know enough to fund. We really don't have enough knowledge here to do this. And at the same time, we got this tension from this legislature. So the division was very careful and strategic in the way they used the indicators to satisfy the legislature, but not put the pressure on the providers, which was engage in the process, provide data, and participate. And that will be, those are the indicators that will be used for funding. I'm going to go to the instruments. So in your handout, there is, behind my presentation, let's go to behind a little summary of my presentation, of our presentation, sorry.
Dan, did you have a question?
I did, Chuck. Was the instrument used at all for level of care determination?
Well, it's not formally, but the instrument, I think you have the instrument in your, you do, okay. The instruments were available to the clinician at intake and were part of the assessment. So they're a screening part of the assessment process, and then the screeners determine the level of care, and then in subsequently they have the ASAM, and they have a different kind of criteria too. Mark's very interested in putting together a level of care instrument. They have a integrated transitional care SAMHSA grant, and they are implementing a couple of level of care instruments that in a pilot basis on a couple of providers. Oh, sorry.
That's okay.
So go to your handout here, and we will. There's a point I want to make before we even look at the instrument, and I think the broad categories we talked about. Why do you do performance indicators? One is for accountability, and the other is for clinical care. It's for utility. And so there's a page on the performance management system in there that talks about how the state's going to use it, how they're going to work with, and that how it feeds into their planning and monitoring and works for accountability. And then there's another page in there that talks about the clinical utility of the instrument. So you've got the initial contact, the Alaska screening tool, which measures for, well, I'm going to cover that later. The client status review, which is the outcome measure. Those two together lead to the behavioral health assessment and to diagnosis, to the treatment plan, services delivery, treatment plan review. One of the things they did with these instruments is they integrated them into Medicaid regulations. So you're institutionalizing what you have here. And then they're paying for it. And so the way they justify the payment for the screening instrument is say this is part of the assessment. And then every 4 months, give or take 2, it's required and is paid for for treatment planning review. So that's how they justify that. So they release some of the burden, and then it's a self-report. You could frame it as a functioning instrument, or quality of life is the way that I'm going to frame that, and you can kind of see the head of it. So those are the two groups, and then the instrument, the client status review, the outcomes instrument is actually included in there as well. And I would like to kind of run through that. So the first, are you completing this for yourself, or what best describes the reason you came in? We've done some work in other states. Allan has shown in some of the work we've done. If you come in on your own, you kind of provide different answers than if you are coerced into coming in.
You say more positive answers.
More positive, that's right, more positive answers. And a lot of people in substance use come in are coerced for one reason or another. So that has implications for the way these outcome change measures come. Then the health-related quality, then the health and quality of life measures, those first 4. The first 3 actually come from the BRFS, Behavior Risk Factor Surveillance Systems, the CDC BRFS, done in every state, every year, right? And everyone familiar with that? I won't go into that too much. But the night, and so they're days questions, 30 days. And how many days in the past 30 which are physical health, including physical illness and or injury not good. And so you can look at when clients come in for an intake and compare what they show with general population, which is a nice measure to demonstrate that people are coming in and they have a problem. And we will see that later. And then we use that same model for the days questions, because there have been a ton of research on that, to ask some other questions about suicide, use of emergency medical services, intimate partner violence got moved into there. This has kind of been reconstructed once. Let's see. We pilot tested the instrument, we changed it, it was put in play, and then this is a revision that is not yet been put in play, but basically the same. What the difference is, this categorizes things into groupings that tell people up front, what are we going to ask you, and kind of orients them, and I think that's better. And then there's substance use, how many days did you use alcohol, at least one, and then 4 or more, and then illegal drugs. There's legal involvement, yes or no, and then arrests and 12 months, so you can see some of the noms in here. Then some health behavior. And then on number 18, what we've talked about so far are all objective measures of quality of life. And there's a toolkit HSRI put out that says, that's layman's work. I don't know if anybody's familiar with the quality of life from layman. He put this toolkit together for HSRI, and they're saying, you don't only want objective measures, you want subjective measures. So you ask what's your housing, what's your employment, how does that work for you? Is the housing good for you? Is it working? Do you have enough income to meet your needs? And then, so if you'll look in there, the third and fourth one are safety. So those were part of what they were trying to measure before. We didn't have objective measures of that, but it asked people, are you safe in your home where you sleep? Are you safe outside? And then the next 3 are supports from people. That's been found in the literature to be related to recovery. How much do people in your life support you, your friendships, your family situation? So those are subjective quality of life. And the scaling, I want to mention the scaling because a lot of times what happened with the initial instrument is they broke those days questions down into 4 categories. 0, 1 to 5, 6 to 10. It didn't work. It didn't work to measure change. You know, people can discriminate 10 points from psychometric theory. So why not get them to discriminate what you can? But I think there's some kinds of problem going to 30, because then some people, concrete thinkers, kind of want to count. You can't do that. You got to estimate. But it works, and there's a lot of literature on that. So that's a good model. The HSRI toolkit that came out of it there used this terrible delighted scale, which I like a lot, which is kind of a compromise between like 4 or 5 satisfied, dissatisfied, which doesn't have the emotional power of terrible delighted. And then the 7-point scale they found useful. So that's 18, and then 19 takes a different tack and asks about services from the agency and whether it affected your outcome. So it's access, appropriateness, and did it affect your outcome? And then then I want to get to the last page, which has housing situation, employment, school. Those are such complex questions because we're required to report on so many levels of detail. We had this really initially in the survey and found people were like, you're just asking them to read too much and to sort through too much and to find a categorization. And we said this, instead of asking the client to complete by themselves, let the clinician just ask them. They can just tell in a second, fill out what they need to, and we hope we're going to get more accurate responses to that. So today we're not going to report a lot on the housing, sorry John, and employment, but those NOMS measures. We're going to really focus on way ahead of myself. Maybe really focus on the days questions, particularly the ones that come from the BRFAs, and then the subjective quality of life. Questions? Slow me down. Yeah.
So if you don't have a survey, you don't have a system. you don't have a data collection method, right? Because if all the providers aren't using this survey.
Every provider's using it.
And how you got that is you actually got it legislated into rule that if you're rendering services to Medicaid recipients or anyone who is receiving block grant stuff, you will use this survey at entry and every 4 months thereafter. If they discharge at 2 months, do they get it upon discharge?
Survey, yes.
How did that ever happen? That you got providers to actually, because I'm gonna tell you, in Oregon, it's a Wild West show. We all wanna do our own thing and we wanna collect data, but God forbid you try to get them to agree on an assessment instrument.
Yeah.
I mean, it's huge pushback.
Yeah.
So my hat's off to you on how you did that.
That's Mark. That's Mark Haines Simeon and the leadership at the division and the OIS process and the trust, external funder of a lot of services, those funders supporting each other.
Right, and what drove this was the legislature threatening to pull a ton of money out of the division. And so there was huge threat. And I mean, I was on a lot of those early teleconferences and the providers are like, data? We're not going to give you our data. And so there was this, you had the same atmosphere, but the legislator had written a report that was not positive about the division. And so suddenly, those who were enemies the day before became friends and allies. And it was also before everybody had invested in a bunch of different EHRs, which I think creates a lot of confusion in this atmosphere now.
Mm-hmm.
So it was a lot of paper-based systems that people were using during the time this was developed, and then they could probably incorporate it into their EHR process. I don't know how they're doing that now. Are the providers now doing it separate?
Okay, that's a good point. AK Ames, the division, bought into the Westat. Remember that substance abuse had a system that went across multiple states, and Westat was the contractor, and then they put in a mental health unit to that, and Alaska bought into that system, and then added these things as developmental additions that any state using that system has access to these forms as well. And there are a number of states that are using that. I know Mark says there's some other states that have expressed interest, but the thing is then they've got the technology and the infrastructure out to the providers to access this system, and it's free to them. So a provider can do their own in-house system, but look at the expense of that when you can use AK Ames. And there's a lot of pushback, and some providers are doing and batching data into this system. But the Anchorage Community Mental Health Centers, God, we don't like the system. It's cumbersome. It's not a slick thing as nice as it should be, but it's free. It's kind of hard to
Did you
beat.
also say, Chuck, that the provider gets paid for the events in which?
Oh yeah. So that's huge. So incentivize. You got threats, you got incentives, and
So I think that there's a platform in Oregon that exists now that for lack of a better term, you could trick providers into doing it because they're going to have to enter data into our MOTH system anyhow. So what you have the opportunity to do within that system, it's my understanding, is that you could require providers to load some standardized information in there somehow, some way. But, I mean, it's like, how do you don't beat them over the head with a stick, right? Because you're not going to get anywhere doing that.
Right.
So you have to figure out how you incentivize them. And part of the win here for them is that you can provide pretty timely feedback in terms of how they're performing as it relates to client level outcomes, right?
Yes, and they have the clinical data technically. Practically how well it works out, I have some concerns, but technically that clinician can look at these data on this system, and they can do it. It's just that having access to it and how easy is it to do it, and they're developing reports that will show change over time. And it's still a cumbersome system. It's not like entered online, but there's a path to do that where it would get dumped in, where the client could enter this thing online before they came in or on the I mean, there are ways to fix that, but at this point, yeah, they have access to it on a clinical basis.
So you've got client level outcomes, program level outcomes,
Yeah,
and then
right,
system level outcomes, right? And everything kind of ties together.
Yeah, it's all tied together.
Chuck, does AK Ames also support billing for Medicaid and other
We're
payers?
building that now.
Okay, because that, I mean, if you don't have that, then providers do need another system.
Yeah.
I mean, the other question I would have is, does this satisfy the JACO or CARF accreditation issues related to medical records? Or do they have to have a more extensive medical record and therefore a more extensive electronic health record anyway?
The AK Ames is an extensive electronic healthcare record that does satisfy those requirements. This is just a piece of AK Ames.
So what he's talking about is the practice management side of things in terms of how a bill gets generated and then shot off in an 834
The billing
5
system
hour.
has yet to be built. I think that's still in the process. Deb may know more about that.
Well, no, I was just going to clarify that the state hospital there is Joint Commission accredited, but they are not part of the AK Ames system.
Yeah, that's really important.
Didn't Alaska mandate or that providers be certified or accredited under some national body?
No.
They did not.
No, the state's adequate.
One other thing, just from Jeff's original question of how you got this to work in Alaska, that hasn't been mentioned, but I think is really important, was patience. If you noticed one of Chuck's slides, the tools were initially developed in 2002, then sort of reanalyzed in 2005, like revised in 2007, 2008. So I mean, we're almost 12 years into the process and finally starting to see some really meaty outcomes that are useful. So it was a long process, it was a patient process that sort of mixed sort of the threat from the legislature with sort of really a bring people along approach as opposed to just beat them over the head.
The largest providers have gotten behind it. They are represented in that voice meeting. Anchorage Community Mental Health Center, and the person that did the treatment assessments for them was a part of it all along. Then Aquila is the largest substance abuse provider. They have 2 researchers that they have hired in Aquila to sit in these meetings because they want to use that internally. So there is some internal use for performance management. It's not as extensive as I would like to see, but you know, it's available and some people are doing it. And the other piece that I'm not totally clear about is how are clinicians using it. I think they're still largely using paper, review the paper. I don't think they're doing the tracking. But there's a path to get there. Great.
So I had a comment on the incentivizing people to provide the data that they're interested in. One of the things we had for a small amount of time, we had a full service consumer run Medicaid provision. One of the things that we discovered, because we were fee for service, that if somebody actually missed an appointment, you were paying the provider and you're missing out on the reimbursement. And the fiscal impact of that was actually pretty significant. You had a lot of no-shows. A lot of the systems where I am will cancel people after 2 or 3 no-shows, which doesn't really serve the interest because they're not coming in. You want them to come in, and you're excluding them. But what we ended up doing, actually, you're talking about paying the providers for complying with the DOSA, is actually considering, we found it was more economical to actually, if the person could get to their appointment on their own and made that appointment, we would put money into an account for them that they could spend on their health and use. You could use it as a mechanism for working with them on things that they wanted to work on. They could choose the thing that was paid for. They would have a basically a health savings account at the agency with a fairly broad definition of what they could use it for.
We're talking about,
and that was actually more economical than either having no shows or, in this case, for what you're talking about, no data.
I think that's really interesting. Yeah.
Where did those funds come from?
It was more, we were losing that money anyway, so we actually, it's the fee-for-service reimbursement that paid for it. And that was
interesting. Okay, we have way too much. It's more useful to have a conversation, so we're just talking. We might get back on some of this stuff later. I should point out that Mark has a really solid foundation built into it. In a continuous quality improvement process. When you look at, even all the way back to their mission, it has changed about 4 times since we've gone along. So that now it says quality of life, improve quality of life for consumers through these things. So all these pieces have to tie together. This stuff doesn't run on its own. Performance-based screen. The AST, I was going to get into it. I'm going to do it quickly because it's a very interesting instrument. We were able to revise, this one really got revised a lot, to not only screen for mental health and substance abuse, because it really doesn't take that many questions to pretty much get there, but we included the PHQ-8, the question, the 9, the suicide questions actually on CSR, so I feel like that's covered. So you have a depression anxiety scale to begin. Trauma-related items, Anchorage Community Mental Health Center had a trauma grant and said, you got to put in some stuff about trauma. We had 4 questions. They're on that. No, that's on the AST. AST. And then adverse experiences. Remember the ACE study? You know that. So people said we really need to include that in here, and we'll report just briefly something about that. And then the client status review has these health domains, the domains, and then the questions that we kind of covered. And then the CSR also has some of the questions in this survey.
Sorry to interrupt. I'm just curious on the trauma assessment of adverse incidents. Did you factor in somehow, a lot of people, if they don't have safety, won't answer those questions at all, or honestly, which is one of the difficulties we had screening people for trauma. We had to ask a lot of real indirect questions rather than...
You're just not going to get some things through a paper fill out, and you just have to recognize that. You're just not going to, if they don't feel safe, they're not going to answer the safety question until they get some level of trust with you.
Part of it is that there's some pretty incredible estimates about people's histories going into the system. Yeah. Trauma plays a very significant percentage of people that are in the system for life as adults. Yeah. And if you have 80% of those people who are trauma survivors, and have your surveys coming back with 10% or 20% answering this question. Yeah.
So you have to recognize, that's a good point, and you have to recognize that when you look at these data. That's going to be underreported, but it's a step. I mean, it's something to just get started with for the clinician to interact with the client about and say, this is important. I mean, it's saying it's important. We're going to ask the question. It's on the table. So at least it's there. Self-report, every 4 months required, documentation, screening, treatment plan. So we'll move on to the proof of concept. 45% of clients, so that's probably an underreport, from the 3 or more adverse experiences. 3 or more was used because it's related to chronic health conditions and health risk behaviors, and that's from the ACE study, so we know that. I do want to point out the highest percent of clients, they're like, it's modeled after the ACE questionnaire, but they're not exactly the same. Some of the questions, a couple of the questions, most of the questions are the same. And so it's close enough to kind of get a comparison. The highest percent of clients reporting positively on one question was lived with an addictive person. 57% of people said they lived with an addictive person coming into this. And there's mental health and substance abuse and co-occurring. Several items, over 1/3 of the clients indicated yes. Physically abused, lived with a prisoner, placed in foster care, lived with mental ill person, all of those had over 1/3 of the people endorse coming into the system. So we think these are going to be useful in analyzing the data later, and we haven't done nearly as much as we would like. And we need some graduate students or some researchers involved in really doing some work with these data. Proof of concept. So we're taking the first 3 measures on the instrument, the CDC purpose, lots of reliability, supplemental screening. Here's intake to the providers for clients that came into treatment for mental health, and what they come in for is determined by the clinician. So this is not client reported. It's not based on the instruments. The clinician reviews the instrument, says they came in for mental health, co-occurring, or substance use, and we're going to be referring to that as we go along. So for mentally unhealthy days, boy, I missed a slide because I was going to do something with the purpose. I mean, with the, let's just go on. 15.8% of people, days. People that came in for mental health treatment averaged almost 16 days reported mentally unhealthy days. 10.6 for COD and 5.1, and this is time one intake. So then what we're going to...
Remember, those numbers are not outdated.
Oh, they've been updated. This was the first data set. We have a paper that this is all based on that you can go get online so that you can do this if you have any interest
I
in
mean,
it.
basically, to say the co-occurring disorders initial mean is lower, is actually higher than is on the screen.
Yeah.
I mean, it's much closer to mental health, people receiving mental health services and is represented there.
So this is the guy that does the heavy lifting and all the statistical stuff, so he knows all the numbers and will answer any of your
But
questions.
there's plenty of data to be analyzed that I can't get to. I mean, this is a very rich data set.
So we're going to, for outcomes, we're going to compare change in days from time one intake to time two 4 months later and really go to 6 or 8, something like that. And there's your change score. Mental health goes to 9.6, COD to 5.5 in this study. I was going to,
And then just move the COD line up.
Move the COD line up, yeah. That was an interesting picture. The tides up in Alaska are 30, 33 feet, so like, you got to park your kayak someplace safe.
You can see where Chuck's true passion is.
So you're looking at figures like that, and you say, well, so what? What's a meaningful difference? So let's get into another piece of information here. And we're going to, Allan's come up with the effect size, which you see a lot in the literature, to say, is the difference meaningful? When you got large numbers, it doesn't take that big of a change, gain score to show statistical significance, but is it meaningful? So there's some criteria for doing that.
Statistical significance is finally being devalued in the empirical literature at long last.
And this has got a lot of attention in the literature, is the effect size, and it's the difference between the means divided by the standard deviation. And that's just to say...
Let me just throw out one thing. If you want to read a really interesting book, take a look at the guy who does the 538 blog.
Oh,
Nate
Silver.
Silver.
His book is really excellent and very approachable for any reader. And he's pretty much in favor of a Bayesian approach, which effect size really represents.
And if you want the title of the book, he'll help you find it. So just to demonstrate what we mean by effect size, what's the difference between males and females? How long would it take a naive observer to figure out that males are taller? And can you tell by just looking? And it's a difference between the height, and then it's a function of the standard deviation. So the larger the effect size, the quicker they would suspect that men are taller. So it turns out, go back. So it turns out that the effect size is actually 0.5. It's a medium. So the standard for that formula is 0.2 is a small effect size, 0.5 is a medium, which is observable, would be something that you could see, and then 0.8 is considered a large. So we're going to use those criteria to in these comparisons in a minute here. And I want to have a chance to introduce our new guest. I recognize a face here. Would you tell us, introduce yourselves, please?
Sure. I'm Dave Wanzer. I work with JBS International in the Center for Sustainable Health and Care.
And I'm Karen Bell, same address. Thank you.
Thanks so much for joining us. And I recognize Dave from NISA meetings a zillion years ago.
At least that long.
We also have.
Oh, sorry.
I'm sorry, I'm Janaki Bose, and I'm from Sanson. I work on the NISTA study.
Awesome. Thanks so much for coming out. We're looking forward to having a conversation about that this afternoon. So if you look back at the chart we had before and look at the change score, the difference between the means divided by the standard deviation gives you an effect size of 0.6. That's an observable difference. That's a median effect size. That's the change on which you expect and you hope, and lo and behold, at least you have. So, and then the same for COD. It's a medium effect size. And on mentally unhealthy days for clients in treatment for substance abuse, it's a small effect size. That's not nothing. And you see lots of problems with that. If you took another step for just clients in treatment for mental health and looked at people in ongoing treatment versus discharge, that's an interesting 6 months later, 4 months later. They come down to, and this is the Burfess score, they come down and discharge to, which is also what you want to see. Now, is that what you'd expect? At least you're seeing it. You know, is it taking people at a high coming in for treatment? They are stressed and do have problems. So, you know, you've got some regression that people are just going to do better. But at least it demonstrates that people coming in for do have problems and do change in time to.
So how do you control if someone's really stressed when they enter treatment, really got a lot of problems? Because it seems like the effect size for the opportunity to get them well faster, you're going to get a bigger effect size. And then is there more of a control so when you go back?
You don't. Because this is not a controlled experimental study in any way, shape, or form. This is taking people as they come in, and I agree with you, if they're coming in, unless they're forced to, they are going to be have less positive well-being than would be the case in general at the other times. So we're not saying that it's the treatment that leads to this improvement. All we're saying is that we're able to measure improvement.
Okay.
And so kind of what you're getting at is a case mix adjustment, and I think there's a path in there from some of the AST data, and we are doing a little bit of that by grouping together clients in treatment, adults, this is adults in the community, so we paired out some pieces of that in treatment for, we would use mentally unhealthy days really just for mental health clients and co-occurring clients, and then we use different measure for substance use clients. So we're controlling a little bit of case mix, but maybe not as much as you would like.
Well, case mixes certainly needs to be controlled, but there's a general issue of when people come to treatment.
Yeah.
That says that they're typically not the same for whatever reason as they might be at a different time.
And the issue when you get to providers is some providers may have more extreme. That's what you're trying to get to.
Because I'm trying to think of from a practitioner, I mean, this would be stuff that you'd want to feed back, that you could get that granular with this kind of feedback to them, right? In terms of how they're doing with their caseload.
Yeah, this is all.
We were actually, so in an integrated care clinic we used, not obviously this measure, but the CDC measure, and we could look at by clinician change. So some of our clinicians did better, but also we could compare it to the county data, and we were in a really unhealthy county, and so we could show that our population was getting more healthy than the county. So you can also look at it from a bigger perspective.
Was that the question on the 5-point question?
The healthy quality of life.
Yeah.
I mean, we had other measures as well, but that's what we could compare our population to the county.
So these three, there are 4 core health-related quality of life items in the CDC's purpose that every state has to, that are core items. And the first one is, how would you rate your health on a 5-point scale? And I'm trying to get to, is that the, do you remember if that's the exact question?
So yes, we asked, what are your unhealthy physical life unhealthy physical life, unhealthy mental health.
Okay.
And then those were the 2 that changed the most, and we could say we're below, we could look at the county, and our hope was that we could show, again, it doesn't show that treatment necessarily is the impact, but that if we were providing services, and again, it was integrated care, so it was primary care and behavioral health, that those services were making a difference in a county that had particularly bad markers for both within the state.
Well, you might guess that you wouldn't get that change if you hadn't had those services. Certainly not to that extent.
You might argue that. So we are talking about the same measure, the healthy days.
Yes,
okay.
healthy days.
And did you have something, Drake?
Yeah, I was just curious if taking it as, you said it didn't actually show the effectiveness of the treatment.
No, I'm saying that we don't know. We can't prove. This is not a causal study. This is just taking data at points in time and looking at, descriptively what's going on.
What I was going to ask is whether there is a way to measure how much services each of those individuals get relative to the mentally unhealthy days. That would be something that would actually point direct back to that.
That's our project this year, is to take high services, low. I've tried to hook those 2 together, and the service data are not as complete as I would like, and so we're having.
One other
And initial
question
diagnosis
is,
makes a big difference too.
Would make a difference.
do they measure people drop out of services as well? The way the Medicaid system works where I am, the budget's all designed sort of around the Hotel California model, where everybody checks in but never checks out.
I'm going to get to that issue. I'll cover that very soon.
So you're going to talk about churn?
That'll be it. I'm going to, the cohort analysis starts to get into that issue. Sean?
I was just going to ask, is there any wait lists that Alaska's running?
Substance abuse in particular, they do have wait lists.
And do they give this measure while people are on the wait list?
That's a good question. It's for substance abuse, for clients going into treatment at a substance abuse provider, it's kind of mixed the way they do it. They might do the AST initially and then not do the CSR until they actually brought in for treatment, and that might be a long time difference, or they might, it depends on the agency. So they don't have their processes set up straight for that. I'm advocating you do that the first time they come in, because that's your high point and that's where you're going to show the greatest change, and then you want to see. Anyway, yeah, we're on the same boat.
So there's a wait list for outpatient?
For substance abuse treatment, I think there's often a wait list.
Okay.
Inpatient or outpatient or both?
Outpatient. Yeah. You got to deal with people that are headed for the hospital and for crisis centers. You got to deal with them. I don't know. You can't just put them on a wait list, right? Then, no, I think we're talking outpatient, and I'm talking adult outpatient here. We've pared this down. That's part of the case mix adjustment. As you look at you group things together so that they are more like. So depending on the measure, 2.5 to 4.5 times this means. Let's look at the other. Here's unhealthy days, which you same situation. Here's activity limitation days, it's the same kind of a thing. Performed as expected, validity supported. There's the document that you can find online. That this is 100 pages. It's like probably 50 pages of text and 50 pages of appendices with detailed data on means and standard deviations and all the stuff that goes into the scores that you're looking at. So Mark said he would make sure that that's up if it's not on his website in Alaska, and we'll email the URL. How's that? Somebody remind me to email the URL. I want to get it. Oh, that's cool. Why
don't we put it on the slide and just send them the
PowerPoint? That'd be a good idea. That is 15 feet on a humpback whale from the front to from the blowhole to the there, and there's another 15 feet front and another 15 feet front behind, and it's pretty fun when they. Cohort analysis. So I want to get a little bit into this. So with the time 1 intake, the time 2, we refer to that as cohort 2. And then cohort 1 we refer to as people that come in and don't have that time 2. They may get services. We don't know how much service and how many drop out. So there's still some analysis. That's what we're doing this year, is trying to look closer at flow through the system, which is John's issue here. This really is going to relate to what we're doing with client level data. Because cohort 3 is, if you are, what I'm going to try to look at is clients served in a year, and if they have an intake, I'm going to take an intake, the first intake, and if they don't have an intake, I'm going to take their ongoing. So that and then we're going to, the cohort 3 is the ongoing. If you look at the ongoing to 6 months later, you've got nothing. You don't have change. If you took intake to them, you would have change. What's going? Ow.
Kind of like the maintenance phase. You're really not seeing change. You got people who are maintained at a certain baseline, and you really wouldn't expect to see much treatment effect.
Well, you can argue that different ways. You could say it depends how much what we want to look at is there a high volume of services going to someone who's maintaining a low, not showing change, then maybe you need to do something different. You got a low volume and you've got a maintenance at a reasonable level, and we'll put that into the OIS committee and we'll have a conversation about what needs to happen with that.
Because I know with the Jeb Brown stuff, what happened is that once you got so much change, what would happen is that if you didn't discharge them, that keeping them in care longer, they'd actually regress back and get ill.
We need to do time 1, 2, 3, 4 and track that through the system. We have not got that.
Oh, that's on my agenda.
That's on the agenda.
I mean, the immediate agenda.
Yeah. But what this is going to do is say, here's how many clients in each of those cohorts represented. Okay, I mean, we're just taking our initial steps into this. And you can see that, so if you, at this point, so we have 3 years worth of data. The first year is maybe not quite as good as the second and the third. It's integrated megs that was required before. Taking the middle year, and I'm going to track every client, one person, for a year forward and a year backward to see what happens. And that's what I'm going to.
You know, just to insert something real quickly, one might think from what Chuck is saying that the data comes to us. And for this client, at this provider, in this program, we have an intake, and then we have a date for their 4-month follow-up, which could be 2 months or 6 months or whatever, and then we have an 8-month follow-up if there's not continuing or whatever. It ain't like that. This data, these records are very messy. We have people who have an intake, continuing, and then some more intakes. And the intakes are from a same agency, a different center and whatever. So what I've done is write a program in SQL code so that you can basically create data sets for each client in a given agency and figure out which of the records are most useful for the analyses we want to do.
So the query looks at procedure codes, and that's how you're kind of trying to figure out how things are.
No, it looks at program type codes.
It looks at the CSR, dates on the CSR,
Yeah, right.
and added to information.
Right. So when we have an intake, it looks to see if there's a continuing after it without another intake or discharge. If there's a discharge, then that's a span. If there's another intake or several intakes, we look for the one that's closest to 4 months away from the intake, plus or minus 2 months. And if we find one, we use it. If we find several on the same day, this has happened, we eliminate all but one of them. We have some criteria for that. And then we do the same thing at 8 months, so that, and however long we want to go. But this is very not neat, nice data.
They're still working on making that more coherent. I'm not exactly, we're not going to look at outcomes with this piece here. What I'm trying to do is get it in. So he's doing client by agency, and I'm trying to look at an individual and track them for a year back and not look at change. I'm not going to be looking at change here. I'm just trying to get some, so our job this year is to profile each of these groups. And so I'm trying to develop, and I'm looking for ideas on how to go about doing that. But so first, let's just start, here's how many are in each group. And so when they do their performance measures change, the way we're doing it, they would be counting about 40% of the population. So what's happening to the rest of it? And so one of the things that was interesting to me, and it gets a little closer to your question, is, well, from that intake, how many people were in treatment prior? Or from that ongoing, you know they were in treatment prior. But from an intake, they might be new to the system and not have received the service in that year, or they might have had an intake discharge. You know, who knows what the pattern is? I'm just trying to do they have a CSR before I'm going to count them in the system, and if they don't have a CSR before, it's going to be here. And then I'm going to divide that world into in treatment for co-occurring mental health or substance use. Okay, so that and that's a percent stack, but then you get the total numbers. And then I'm going to take the cohorts and break that down into served in the prior year or not. Okay, so here's cohort 3, which is in no CSR, let's see, ongoing, no intake in the year, and so mental health clients, and not substance abuse clients. And this is what's going to bite us, I think, when we get to the client level data stuff, is they're going to be adding all that in here with no change, and with these intake discharge, mental health or substance abuse. Here's no intake in the year. Oh, this is on. Let's see. No. 2 has they have an intake in the year. No CSR in the prior year. And no, that's wrong. They have a CSR in the prior year. Here's the ones that do not, here's the intakes, the cohort 2 that have no CSR in the prior year. I call those new clients. Okay. And here's the ones that have been in treatment the prior year. Okay, so there's your getting into your churning piece, people that are going in and out. But look at how many of them are new. I mean, I was a little surprised by that. I'm hoping for better data, but
Yeah, there is one problem with that, and that is that in this system, people can have different client IDs.
So they're duplicates.
And
sure.
So they're not uniques?
Well, they're
not, each person, well, a person can have a client ID, and at another agency, they may have the same client ID except for the middle 3 or 4 characters. And we really haven't dealt with that yet.
We could get cleaner with that. They have a system in AK aims to assign unique IDs, and how clean that is the issue Allan's raised. And what percentage of people can you make an estimate? Is that a problem for?
Yeah, that we haven't done.
We haven't done, but I think that it's still useful to look at.
Yes.
It's the best we have, and it's a reasonable point that you're going to have to. How am I doing time? I got to give Allan some time.
Yeah, I'll take 10 minutes. 10 minutes.
That's about what you have. Okay.
That was quick. Or have you here?
Well, I would go to the intakes with no CSR in the prior year. The ones that don't have a time 2, they're practically all new people in the system. So they're getting what they need out of the system before they complete that second CSR, which the criteria for the center would be 6 months. So they're dropping out just 6 months. We need to go in and look at how much service they're receiving. Is that they come in period and that's it? Or just an evaluation only, or they come in and get some treatment and short-term treatment's what they need, and they're gone. You did see in one of the slides earlier, their intake scores look very much like these intake scores. They're not more or less days on any of the measures that we looked at. They look very much like that. Go ahead, John.
One quick question. What happened to the legislative threat to reduce funding to the division?
It's still on the table. Well, the legislator is still there. The threat is gone, but the expectation is that something performance-based funding is done. And what we're working towards now, Allan, and what Allan's going to talk about is we're trying to develop a system that will compare the provider with the statewide average, and show a meaningful difference. And most providers, you're not going to show a meaningful difference, so you're not going to touch that. And a soft touch is the way I'm. And then you've got a few on one end and a few on the other end that you might I would argue for a small pot of new money to be put into something. Light touch, and then satisfy that requirement that you're putting performance-based funding into effect, but not make it so heavy on providers because you don't know enough to do this well. You want to keep it light. Do you know?
So, is there a way? Do you have information that informs whether or not intermittent treatment versus ongoing treatment is
we
the
need to
outcomes
tie
on this?
the service data to this.
Because I think we assume that if somebody stays in treatment, that's a good thing.
Yeah.
But I'm not sure. I love the concept of the clinical, what was it, the clinical delusion or illusion that we talked about yesterday? I don't know. I wonder if some people do better coming to us when they need us rather than coming to us every week on a regular basis just because they came last week.
Yeah.
So I don't know if there's data about
Our
that.
data certainly shows that the change from intake to, say, 4 months is much larger than it is from 4 months to 8 months.
I think we'll get a change there, but after that point.
And if we just compare continuing to continuing without an intake,
yeah,
the change on average is very small. But of course, that's not a clean comparison because it's self-selection, well, both self-selection and agency selection in terms of who stays for how long.
So we
I
need
think you could guess that most of the change, I think there's other literature that supports this, is going to happen early on, or even before they start coming.
Yeah.
There's evidence that says that people start getting better, just knowing that they're going to start receiving services.
making a decision to go, or having it decided for you. That's what we need to do with that cohort 3, is to tie the services to it, see how much is going on there, and raise the question of if there's resources going in and nothing's happening.